Hey everyone, and welcome to this explainer. Look, if you're a certified nursing assistant, you are literally the ultimate frontline defender when it comes to your patient's skin health. Seriously, you're the eyes, you're the hands, and you are the absolute first line of protection against a silent, fast-moving threat, pressure injuries. So today, we're going to break down exactly how these injuries form, how you can spot them, and most importantly, the highly specialized techniques you're going to use to stop them right in their tracks. Okay, let's dive right into this.
Here is our quick roadmap for today. We'll cover the mechanics of injury, staging the damage, assessing patient risk, frontline prevention, and finally, assessment and reporting.
All right, let's kick things off with Section 1, the mechanics of pressure injuries. Now, you might be wondering, what does 32 millimeters of mercury actually mean? Well, it's the normal blood pressure inside the tiny, delicate capillaries that feed our skin. It's really barely any pressure at all. But when a patient lies down on a standard mattress, the sheer weight of their own body easily exceeds that 32 mmg. And when that happens, capillary blood flow is completely cut off. The cells are suddenly instantly deprived of oxygen and vital nutrients, and they literally begin suffocating in their own metabolic waste.
And here is the truly scary part. We have very little time to stop this. You might hear a lot about a standard 2-hour repositioning schedule, right? But in high-risk patients, we're talking the elderly, the malnourished, or the critically ill, ischemic tissue damage can initiate in just 30 minutes, half an hour. That is exactly how fast cells begin to die when they're starved of oxygen under the heavy weight of gravity.
So what are the actual forces causing all this destruction? Well, it comes down to 4 mechanical forces that you absolutely need to memorize. First up is pressure. That's that direct, perpendicular force squeezing the tissue right between a bone and the bed. Next is shear, which is a lateral, sliding force. Third is friction. Think of this as surface rubbing, kind of like dragging skin across rough sheets. And finally, moisture, which just completely softens and weakens the skin structure. Now here's a totally crucial point regarding moisture. If that moisture is from fecal incontinence, it is highly destructive. Intestinal enzymes will literally chemically attack the skin, massively amplifying the risk of a pressure injury.
Let's clear something up right now, because 2 of these forces, shear and friction, get confused all the time. Friction is what you can clearly see right there on the surface. It's an abrasion or a scrape on the outer skin from rubbing. But shear, wow, shear is a silent killer. When a patient slides down in a bed, their skin might actually stick to the sheets, but their heavy muscle and fat slide downward inside. This causes invisible, internal tearing of the capillaries deep beneath perfectly intact skin. So a wound might look like a totally minor issue on the surface, but shear can cause massive hidden destruction underneath.
Moving right along to Section 2, staging the damage.
Okay, let's do a rapid-fire walkthrough of the official classifications. Stage 1 is intact skin that does not turn white or blanch when you press it. You've got to report this immediately. Stage 2 is a shallow, open wound with a pink or red bed, or it could be a blister. Also immediate. Stage 3 is deeper. You can actually start to see subcutaneous fat. This is an urgent report. Now, Stage 4 is an absolute medical emergency. This is where bone, tendon, or muscle is exposed, and it carries a massive risk of life-threatening sepsis. We've also got unstageable, where the wound is totally covered in dead tissue so you can't even gauge the depth. And finally, deep tissue injury, or DTI, which looks like purple or maroon intact skin.
You really need to think of a Stage 1 injury as an iceberg. Remember a minute ago when we talked about pressure? Well, the highest pressure is right next to the bone, and that means the deepest tissue dies first. By the time you actually see that non-blanchable red spot on the surface, the underlying tissue may already be extensively dead or damaged. That visible skin breakdown? It's literally just the tip of the iceberg. You absolutely must treat Stage 1 findings as true emergencies. Which brings us to Section 3, assessing patient risk.
In the clinical world, the Braden scale is the gold standard for predicting risk. Now, nurses formally complete this assessment, sure. But as a CNA, you interact with these patients the absolute most, so you've got to understand it. The Braden scale measures 6 key areas: sensory perception, moisture, activity, mobility, nutrition, and friction and shear. The absolutely crucial thing to remember here is that lower scores mean higher danger. A score of 1 in any single category, like a patient who is completely unresponsive to discomfort, constantly moist, or totally immobile, means they are at extreme risk.
But what do those scores actually mean for your physical actions on the floor? Well, they're your daily playbook. If you see a score of 15 to 18, that's mild risk. That's your cue for strict 2-hour repositioning.
At 13 to 14, moderate risk, we actively step it up. We add heel offloading and specialty surfaces. High risk, meaning scores of 10 to 12, means you are repositioning every 1 to 2 hours, minimum. And if they score a 9 or below, that is very high risk. They need hourly repositioning or as much as they can tolerate and the absolute highest level of support service available. This isn't just some chart to memorize. This is your active moment-by-moment strategy on the floor.
All right, Section 4, Frontline Prevention Techniques. This is where you actually stop the damage.
Okay, these are your absolute non-negotiable repositioning rules. First up, you have to lift the patient completely using a draw sheet. Never drag them. Dragging causes instant friction and shear. Second, use a 30-degree lateral tilt. Whatever you do, don't put them in a full 90-degree side-lying position. That just transfers all the pressure straight to their hip bone. Third, smooth out all wrinkles in the sheets and ensure absolutely no medical tubes are coiled underneath them. Fourth, keep the head of bed at 30 degrees or lower to stop shear on the sacrum. And finally, never use donut cushions. No way. They actually concentrate pressure and completely cut off the blood supply to the wound edges. Following this protocol exactly is your best legal protection and clinical tracking tool.
Now let's talk about heels. The heel has almost no fat to pad the bone, making it incredibly, intensely vulnerable. Correct offloading means placing a pillow under the calf so the entire heel floats completely in the air. Incorrect offloading is putting a pillow right under the heel itself. That just shifts all that dangerous pressure directly to the Achilles tendon. So here's your quick floor test. If you cannot slide your hand flat under the patient's heel, it is resting on the bed and it is in danger. You need to fix it immediately.
Remember earlier when we talked about fecal enzymes destroying skin? Yeah, it's bad. So here is your specific defense, the 3-step incontinence skincare protocol. Step 1, cleanse with a pH-balanced, no-rinse cleanser. Do not use regular soap. Regular soap completely strips the skin's natural acid barrier. Oh, and pat dry, never ever rub. Step 2, protect. Apply a barrier cream, like zinc oxide or dimethicone, to physically block that moisture. Step 3, assess. Look closely at the skin and document its exact condition during every single episode of incontinence care.
Finally, Section 5, Assessment, Action, and Reporting. To make your skin checks completely systematic, just memorize the DATA framework. It's your mental checklist for every single bath and every repositioning. D is for discoloration, so you're looking for red, purple, or maroon spots. A is for alterations in texture. Does the skin feel boggy and mushy, or is it super firm? T is for temperature. Is the area unusually warm or maybe strangely cool? And the final A is for architecture. Are there any open areas or tiny linear tears in the skin?
Now, this is absolutely crucial. Standard redness checks completely fail patients with darker skin tones. You simply cannot just look for red. You must rely heavily on touch. Use the back of your hand to feel for temperature changes. Warmth means inflammation is happening. Palpate the tissue. Boggy or firm areas mean deep damage that you can actually feel way before you can see it. Use tangential lighting. Basically, shine a flashlight at a sharp angle to cast shadows on any subtle texture changes. And finally, always compare the skin to the patient's own surrounding skin tone, looking for any darker or lighter variations.
And when you do find something, well, here is your ultimate directive. Any new area of skin breakdown, regardless of size, must be reported to the nurse before the end of the shift. Guys, this is strict. It is non-negotiable. Do not try to treat it yourself without a nursing order. Your role here is incredibly clear and absolutely vital. Find it, describe it accurately, report it immediately, and document it.
So, we've broken down the terrible forces tearing at the skin, the warning signs of every single stage, and the precise physical maneuvers you need to block the damage before it even starts. You know the stakes. You have the tools. The only question left is, are you ready to be the ultimate frontline defender for your patient's skin? Thank you so much for joining me for this explainer. Now get out there and protect those patients.